This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everybody to our 19th episode in our Pediatric Hospital Medicine podcast series. I am your host, Dr. Tony Tarchichi, here at UPMC Children's Hospital of Pittsburgh, continuing our march down Pediatric Hospital Medicine. Now, today we are going to talk about hematology, and we are specifically going to talk about venous thromboembolism and thromboembolism prophylaxis in pediatrics.
Additionally, I'd like to remind everyone that we have free CME associated with every podcast. Please click on the link at the bottom of the podcast description, and you go to the University of Pittsburgh website, get a free login, answer a few questions, and you get free CME credit for this, AMA Category 1. Thank you to the University of Pittsburgh for continuing to offer this free CME for this podcast. We're going to adjust how we do things just a little bit. Up until now, we have been using the Journal of Hospital Medicine's Pediatric Core Competencies published in 2010 to guide how we go about making the content for this podcast. Well, recently the American Board of Pediatrics has come up with the Pediatric Hospital Medicine Content Outline, which is it's what we're going to be tested on for the boards. So we are going to begin using the American Board of Pediatrics content outline to figure out what exactly we should go over for this podcast. So today,
we are fortunate enough today to have Dr. Frederico Xavier, MD, MS, here with us as our special guest. Dr. Xavier is an assistant professor here at the University of Pittsburgh School of Medicine. He's a faculty member of the Department of Hematology Oncology here at UPMC Children's Hospital of Pittsburgh. He is the clinical co-director of the Hemophilia Center of Western Pennsylvania and the director of hematology clinical research here at UPMC Children's Hospital of Pittsburgh. So, Dr. Xavier, thank you for joining us.
Dr. Tarchichi, thank you for the invite. It's a pleasure to be here.
So we have to do our disclosures first. So I have nothing to disclose.
Neither have I.
Wonderful. So, Frederico, I have to be honest with you, this is not a topic I knew very well when I started to create this podcast episode. And there's more here than I expected to be here, but there's also less. So a lot of this is based on not enough evidence. A lot of the recommendations from the recommendation groups, the American Society of Hematology, a lot of their recommendations are based on poor evidence.
That's correct, Tony. Unfortunately, the hematology, the pediatric hematology, due to, first, it's a rare condition, right, to have clots in pediatrics. And second, because we are not as organized as our partners, the oncology, in terms of standardizing protocols and treating the same way. Each individual institution has its own way of doing things, and unfortunately, I'm not doing a good job on collaborating. But now there's a huge effort internationally, especially here in the US, to try to standardize more and to create a more robust data. But you're correct. Most of the data that we use, it comes transplanted from adult medicine.
So the first thing we're going to review today is the American Society of Hematology's 2018 guidelines for management of venous thromboembolism, treatment of venous thromboembolism. This was published in November 27, 2018, so hot off the presses. And this was in the Journal of Blood Advances, Volume 2, Number 2. And the head author here is Dr. Paul Monagli with Carlos Coelho and Caitlin Augustine et al. So first they discuss kind of the pathophysiology. And one of the interesting things here that they talk about later on that I picked up, so they discuss a construct for thinking about thromboembolism in children. And they say that venous thromboembolism occurs when more than or equal to one component of Virchow's triad is activated. So that includes stasis of blood flow, injury to the endothelial lining, or hypocoagulability of blood components. And I thought that was a nice layout to start out. And one of the things I did not know is the incidence of venous thromboembolism, which we're going to call VTE to make it easier for us. First of all, in the average pediatric patient, it's very low, 0.07 to 0.14 per 10,000 children. But in hospitalized kids, which is those of us listening who take care of hospitalized kids, the rates increased 100 to 1,000 times fold. which they say is greater than or equal to 58 per 10,000 admissions, which is the reason we're talking about it, because this is much more prevalent for sick and hospitalized patients. So as a group, hospitalists have to know more about it. And the most common age groups for VTE are neonates and teenagers. And the most common precipitating factor, which I think all of us kind of know if we take care of kids, is central venous access device, or a central line of some type. And about 90% of VTEs in neonates and greater than 60% in older children are related to these central venous access devices. So I'm good so far, right?
Correct.
Okay. What I didn't know is there's no anticoagulant drugs actually approved for use in children. Is that right?
That's correct. If you look at the FDA inserts of all the drugs that we've been using, they have no formal FDA approval for pediatric group.
That's amazing. And all of the new fancy, so I'm, for those of you at home, I'm also a med-ped, so I'm internal medicine trained. And on the medicine side, a lot of the new anticoagulants like digabitrin, rivaroxaban, who's, I'm sure I'm butchering these names, abipaxaban, they're being used a lot on the adult side. But for pediatrics, they didn't even put them in the guidelines. They're out of the scope of the recommendations because they remain investigational in children. There's no published safety or pharmacokinetics. And they know, the panel did say that, trials are ongoing, so maybe next time. But for now, they didn't even put them in the guidelines. So how early are we in the research component of learning about these drugs in kids? Very early?
No, so you know that the people start using off-label anyways, especially in the teenage group. So then we have been seeing a significant amount of the use of so those new drugs are called the direct oral anticoagulation, directed target oral anticoagulation drugs, right? So the teenage group, because they say, well, they should have a similar, because the most problem that we have is the PK, understanding the PK of those drugs, to make formal recommendations in drug dosage. And then teenagers, the PK should be close to adult PK, but it's still, there's this group between 12, 16 years that you still can have a different PK than adult population.
No, when you say PK, you mean pharmacokinetics?
Sorry, pharmacokinetics, yes.
Okay.
So then we do have a lot of phase 2, ongoing for pediatrics to try to understand PK in this group population. But it's a hard sell because there's FDA because pediatric population is considered one of the risk populations for study. Mm-hmm. So there's a lot of regulations and monitoring and a specific group that you can use. So it's a hard sell to convince a parent to give the drug that the kid is healthy, and then you have to poke the kid that we know how hard it is to get pokes, and then to convince the family to do a PK study on them. Okay. So that's why pediatric always lags behind in terms of, but we're trying to use patients with central lines and with some kind of underlying condition that they are already in the hospital, but we haven't enrolled enough patients to be able to come up with a robust PK and recommendation. That's why we don't have formal recommendations for those.
Now, marching down these recommendations, the first one makes a lot of sense. The ASH, the American Society of Hematology, recommended using anticoagulation rather than not using it in a pediatric patient with a symptomatic DVT or PE. And again, all of this comes with poor evidence, and this one was strong indirect evidence from the adult literature.
Right.
So that one made sense to me. If the kid's symptomatic, you should anticoagulate.
You should treat, right.
The next one, it took me 3 or 4 reads to really make sure I knew what they were saying. So the next one, recommendation 2, basically says do what you like. They talk about suggesting either using, they suggest, they don't recommend, either using or not using anticoagulation in a pediatric patient with an asymptomatic DVT. And they discuss there's no support, obviously, for routine screening, radiologic screening for asymptomatic venous thromboembolism, but if you happen to detect it looking for something else, then you can or cannot do it. They don't want to give strong recommendations. And then they talked about, because in anticoagulation, the frequency of major bleeding in children treated with it ranged anywhere from 0% to 21.8%.
Right.
So it's a huge range.
Right.
And so it depends on the risks of that individual patient.
Correct.
It took me 2 or 3 reads to understand that, but
so then the question is, right, in pediatrics, because this is mostly due to two reasons. One is that, do we know if any line on a pediatric patient, due to size and lumens that we've been using, so is it normal to find a clot around the line in a non-symptomatic patient? So we don't know that. So that's why that's one of the reasons. Because people find line-related clots sometimes, those that we call the glove clot, that are around the line, not causing obstruction of the vein. We don't know if this is something normal, that's something that's going to go away by itself, so it's something that should treat it or not. So that's why this is one of the reasons. The second one is that one in adults as well they have is the asymptomatic subsegmental PE. So do we need to treat those patients that have no symptoms? Because in pediatric, we have a lot of lung disease, right? And especially wintertime, and kids do not have a good breath, and then you have a CT, and then the CT says, oh, maybe you may have PE, a subsegmental PE is not clear or not. So do we need to invest in treating those or not? And the third one is those kids that when you start doing all those images, because they are super sick, right? So then that's why different than adults as well, then the risk of having a bleed from your therapy, it starts increasing. So that's why it's case by case, and we do not have strong data to tease out those questions because we don't have standardized looking for this, right? We don't scan everybody just like a baseline like lung to make sure they don't have a P when they start with, or we don't do ultrasounds in all single line that we have in the hospital.
So then would you say if you're a hospitalist and you have someone central line and you happen to find a clotter on the line because you're ultrasounding for something else, and you see it?
Yeah, most likely it's because your line is not working properly, but
right.
The kid has no edema, no pain, no different color, no different temperature. It's just the line that is acting up, we will say so. And then you do an ultrasound and you find a glove around the line, a clot that is non-obstructive.
And do you want, as a hematologist, do you want to know about that patient?
So that's academically, we would love to start creating a database and collecting data, but it's kind of impossible, right? If I say this and then my coworker that's going to be paid all the time is going to kill me. So you can try to come up with a plan inside your institution as long as you have a support from the heme group. So some places they say if you are asymptomatic and you see this and then there is nothing else concerning you that causes giving trouble to the patient. Where I train, right? Because I train in a bunch of different places, so that's why I have more of experience about doing different things. Some places they do tell you, watch it. Repeat the ultrasound in 2 weeks and see what happened. Does it progress? Does it go away? Or as long as your patient remains asymptomatic. But yeah, it's not crazy to do this.
So then maybe creating a clinical effectiveness guideline, incorporating this.
Standardized
guideline,
right.
Meeting with your hematologist. Well, because we know we're going to see these patients.
Correct.
It's not a question of if, it's a question of when and how many.
Right.
So then we have a plan set up
right.
and have clear ideas when to talk to hematology versus when to observe.
Right.
And if you're a hospitalist in a small institution, let's say a community hospital, let's say you don't have a hematologist on staff, is this a patient you would transfer to a bigger hospital? My inclination would be to call the bigger hospital's hematology group. I'm sure I can get a hold of somebody.
Right.
Ask them what they think, and maybe then set up some sort of guidelines as well when to transfer. But if the child looks very well and has no other issues and is obviously stable, mm-hmm. I would call and talk to them, but I don't know that I'd transfer that patient. Do you agree?
Yeah, so then it's a good question, right? Because of the busy patients, busy doctors, centers, and then we don't have the capacity of checking ourselves and being close to you. I think that most of the hematologists then at that point will tell you to treat the patient. And especially nowadays that hopefully at some point we're going to be able to give the data for the 6 weeks versus 3 months of the provoked length of therapy. Mm. And then those patients are going to be in having a 6 weeks course, or even if it's just a central line non-obstructive, maybe even like a shorter anticoagulation course, like 2 weeks, and then you tell to repeat ultrasound and then you go from there. But I think that outside of a place that is not collecting data, I think they're going to err to go ahead and treat it, and then take a look in 2 weeks or 6 weeks, depending on how your hematologist is going to talk to you. But I don't think it's going to be a reason to transfer that patient just for that.
So then call the hematologist at the big center,
right?
See what they say. So the third recommendation says that they suggest against thrombolysis followed by anticoagulation instead of just anticoagulation alone in a pediatric patient with a DVT. They said in most cases the risk of thrombolysis outweighs the benefits, but there may be some minority of cases where the opposite is true. And short of a patient having a DVT and also having sepsis, where they're actively very, very ill, in my mind, I can't come up with a reason why I would use thrombolysis in a DVT alone in a patient who's stable.
Yeah, so that's the scenario for this. The controversy is that, so it's your healthy teenager with a massive DVT, right? So those teenagers, they can have anatomical reasons for have those gigantic clots like May-Turner syndrome or thoracic outlet syndrome, or all the inflammatory disease that, especially IBDs, that they have come up with the massive clots. Because then the question to you is that, what is the incidence of post-thrombotic syndrome in this group, in this age group, right? Because they have a long life ahead of them. So then, does it matter if you are more aggressive trying to clear this burden of clot in this patient to prevent them from having post-thrombotic syndrome or not? Because the data for this comes again from the adults that they show that being more aggressive does not improve incidence of post-thrombotic syndrome, and even like expose them to a higher risk of bleeding. But then you can say that adults have a higher risk of bleeding anyways, generally speaking, than a pediatric patient. But that's the scenario that we need to consider case by case. So it is a teenager with a big burden clot, and because the risk of post-thrombotic syndrome looks like it's not, I mean, everything in hematology, there is not strong evidence, but looks like they are more susceptible to have post-thrombotic syndrome, and maybe in a very experienced center that you have interventional radiology, pediatric interventional radiology, a good hematology team, so maybe those patients should be elected to have a more aggressive therapy, meaning a thrombolysis, pharmacological or mechanical, to decrease their risk of post-thrombotic syndrome. But as I say, we don't have this data yet. But maybe in centers that do this frequently, maybe is a good patient to be a candidate for doing that in a stable patient. Yeah.
Can you talk for our viewers listening at home, what is post-thrombotic syndrome?
So post-thrombotic syndrome is an entity that we don't know who is in higher risk or not. People believe that maybe those that have non-resolution of the thrombosis, meaning they remain with the occlusive clot, but even those we don't know what is if they're occlusive, we have more risk of a partially occlusive clot after the anticoagulation therapy, right? Because the anticoagulation doesn't do anything to the clot itself, you just prevent it from growing, and then your body has a job of breaking it. So then they say, well, what if we break it to prevent this? Post-thrombotic syndrome then is like later in life, you still have abnormal flow in that limb, and that causes the whole poor blood return at the end of where your clot was. So then you're going to have abnormal size of the limb because of the stasis. You're going to start having ingurgitation. Some patients may develop pain because of the muscle stretch and nerve compression, lymphedema because the venous congestion and then subsequent lymphedema. And then the worst case scenario is like chronic pain, incapacitating, and even the development of ulcers. So that's the extreme of the post-thrombotic syndrome. But I've been doing this for 10 years already, and then I've seen patients with a thoracic outlet syndrome, they're pretty healthy teenagers that are swimmers, like competitive guys that then we develop those clots, come back to the hospital, we treat them, and then they're never back to the same. So they cannot swim as good as they have before. So that's why there's this concern. So some patients develop chronic pain, and then because they have so much ahead of them. So that's why this question that should we be more aggressive? But we need to have a better data to make this formal recommendation. But maybe in centers that are doing this all the time should do it. And then maybe if you have a patient that fits that picture, you should refer them for those patients.
So then if I'm understanding this, the whole reason behind even considering it is the concern for post-thrombotic syndrome to maybe decrease the incidence of it.
Correct.
But we don't know how much of it occurs in pediatrics.
Correct.
The incidence, and we don't even know if this would decrease the incidence one way or another.
Correct. Seems that it does, but we don't have that yet.
So in bigger centers, like you said, that do this a lot, where they may have a lot of expertise in this, and they'd be something to consider.
Correct.
Okay. Now, the next one, recommendations 4 and 5 are linked. They suggest against using thrombolysis, followed by anticoagulation for a pediatric patient with a PE. So don't use thrombolysis unless the patient has hemodynamic compromise, which they call the massive PE. So if you have a PE with hemodynamic compromise unstable, thrombolyse with anticoagulation. If it's just a PE that's not massive or submassive, then don't thrombolyse, use anticoagulation.
Correct. Yeah, pediatric population seems to be, again, not enough, but that they do well. So that's why we don't think that we should be as aggressive in that case. Because the lungs, right, the concern of post-thrombotic syndrome, you don't have that. And coagulation, as long as you start with achieving therapeutic levels. So that's why nowadays they even say that if you can and your patient is stable enough, just go ahead and start with a low molecular weight heparin to achieve a therapeutic as soon as you can to help your patient. And you don't need to be as aggressive with the pharmacological or mechanical thrombolysis. Yeah.
So the next one suggests against using thrombectomy followed by anticoagulation in a pediatric patient with a symptomatic DVT or PE. Instead, they recommend anticoagulation alone, but they did talk about in certain cases like cardiovascular compromise, secondary to venous thromboembolism, a thrombectomy may be appropriate, but they said these cases are rare.
Correct.
Okay.
And as I say that for some reason it looks like the pediatric population, they do a better job than adults in breaking the clot acutely. So that's why pure anticoagulation with our old school heparin or whatever you're familiar with, it works.
Okay, and there's another paper we're going to get to that gives a couple of theories as to why that is, why kids don't get enough clots, or as much clots, but we'll get to it. Mm-hmm. All right, marching down, recommendations.
Well, yeah, so just to summarize, right? So if you have a patient that has a limb-threatening, a life-threatening clot, those are the ones that you should consider for mechanical thrombolysis. If that's not the case, then it's okay to do standard anticoagulation. And then the exception for that is the teenager that with a massive clot that is stable because of a limb clot, and that you wanted to maybe decrease the risk of developing post-thrombotic syndrome. But that's pretty much what the being aggressive and non-aggressive case is. So if you have a life-threatening or you have a limb-threatening or an organ-threatening clot, so those are the situations that you should go there and break the clot to save the organ limb of the patient itself.
Yeah, that's what it seems like. They only want you to break up the clot in really serious cases.
Correct. Or that's the case where the teenagers with the risk of developing post-thrombotic syndrome.
And in those cases, those patients would be either in the ER or the ICU. I assume hematology is going to get called and be involved from the beginning.
Yeah, actually, we would love that, but sometimes, especially the teenagers, right? Because there's always this gray zone where they go, if adult hospital or a pediatric hospital. So those are the ones that we sometimes miss, right? So that's the teenager that is on the birth control, a little bit overweight, comes with this big clot, and they say, just go home, take your anticoagulation and done. So this is the group that we miss, and we don't know if they're going to develop post-thrombotic syndrome or not. But the other ones, yes, the sick kids with limb, life, or organ, yeah, they're going to be in the hospital, and then the hematology will be involved. If they're not, they should be referred to a center with a pediatric hematology. But the ones that we would love to hear from as always that those teenagers as well with the big extensive clots, right? They are stable walking around, but we still should consider for something more aggressive if you are in a place that can afford that.
Now, the next recommendation begins to talks about IVC filters, and they don't like IVC filters. They suggest against.
Right. Yeah, that's it. It's from adult data has a very strong data on that, and in peds is all we're trying to keep away from. Because once you put a filter on, you have to be on anticoagulation for long term to prevent the filter from clotting anyway. So nowadays, pretty much you should put a filter only if you cannot treat, and then you put a filter there to avoid the clot from traveling. Sometimes doing procedures, if you're doing the thrombolysis, thrombectomy, sometimes they put a filter there just to doing the procedure when they're breaking the clot to avoid the filter to go, and then after they remove it. But some centers are not even using anymore. But yeah, we don't like filters anymore.
And they even say if you put one in, you should have a clear plan to remove it.
Correct.
It shouldn't be put it in, it should be put it in
forever. Right.
And then I didn't know you can't even put filter in a kid less than 10 kilos. I mean, it makes sense, they're tiny.
Right, so that's all the size of the vein, and then all the paraphernalia, the mechanical things that we have that don't go that low.
All right. So now 8A and 8B, I wrote a lot. They're long and they're connected. And they suggest only using standard anticoagulation alone in a patient with a DVT or a cerebrospinal venous thrombosis or a PE, and not additionally using antithrombin replacement therapy, unless you have a patient who failed to clinically respond to standard anticoagulation treatment, and when repeated measurements of their anti-3 concentrations reveal low antithrombin levels based on age-appropriate references. Now they go on and talk about some patients could benefit from antithrombin replacement therapy, specifically those if obviously you have an inherited antithrombin deficiency, if you have low levels of antithrombin, if you have ALL, acute lymphoblastic leukemia on induction asparaginase, other chemotherapy, kids with nephrotic syndrome, neonates, post-liver transplant patients, and finally, kids with DIC or venous thromboembolism.
Right. So that's a long topic now. It's so it involves a bunch of different things. So the first one is, in pediatrics, there is a lot of people that defend that you should consider the physiology of your patient, right? So then we know that a bunch of the proteins are, we call the developmental behavior of some of the clotting proteins or the anti-clotting proteins that follows your age and your liver maturation. So babies and neonates, they have lower proteins that we should be aware of and not trying to transform them in an adult, because the protocol comes mostly from adult data, and then you keep trying to transform your patient to an adult to follow your protocol, to have nice numbers and to not be concerned about. So that's why the hematology always should be involved in those cases, because we try to adjust a little bit more than the adult guys. But the other question behind this is monitoring heparin, right? So heparin is an agent that is target multiple proteins, right? It's not only 10, right? So that's why you measure the anti-10. If you're doing that, we strongly recommend you do that, to not use PTTs anymore, right? PTTs are global assay. There's a lot of proteins involved. Some of them are acute phase reactants that can be high and then falsely shorten your PTT because of, like, one of those are 8, for example, factor 8. Goes sky high if you're inflamed, and can bring your PTT back, and doesn't mean that you're not giving enough heparin. It's just because you have a lot of factor VIII then, and in vivo your heparin maybe you're working, but in vitro your lab is going to be abnormal. The other, as you said, is the consumptive status of losing proteins, right? So if you don't have enough because of chemotherapy, asparaginase that impairs your protein capacity of producing protein, or you're leaking, like your renal nephrotic syndrome, you're losing antithrombin, so then you should replace those, or you're on a not full-blown DIC, but already consuming some of your proteins as well. But the question behind this is that, what is heparin resistance, right? Because then you're following your PTT or you're following your anti-10 and you're not on target, and then you start increasing your heparin. Heparin works through antithrombin. So one of the answers that easy to do this is to bring the numbers. Doesn't mean that you know what is happening in vivo. Is give antithrombin, because your heparin is going to be more efficient, and then you're going to normalize your labs because of your protocol. So that's when the pediatric doctor needs to be involved to make this call. So are you really a heparin resistant, or are you not maybe monitoring your heparin adequately, or it is a situation that you should consider giving antithrombin? So like a ballpark is that if you are off therapy or off range on your heparin, and you have a life-threatening situation, you should, and you have a low antithrombin on the lab, you may think about it giving antithrombin just to at least know what you're doing, following your protocol, and knowing to bring the numbers to a, in quotation marks, normal range, because you're giving antithrombin and then your heparin is going to be working more efficiently. But does it mean that you're doing anything in vivo different than before with crazy numbers? We don't know. So that's why the hematology in those cases should be involved. But in life-threatening situations, you should consider giving, if you have a lower antithrombin, just to be able to monitor more adequate, right? So just to remember, heparin targets factor 2, factor 10, maybe a little bit of the 9 as well. So some kids we don't know, some blocks other proteins instead of only the 10 when you monitor. That's why the confusion and discrepancy between 10 and PTTs. So there's a lot of to discuss that, but that's why antithrombin replacement should be considered only on a very unique group of patients that you are having a hard time giving heparin. And that's why, as well, some centers nowadays are even changing to known heparin agents in those situations that you really need to be strict on being on target on your administration of anticoagulation because you are following a protocol.
If I understand this correctly, then this comes from the idea that if you're on heparin, there's an element of kids who have some heparin resistance, whether that's due to consumption of proteins and a consumptive coagulation.
Right, so that's why the resistance in this case is like quotation marks, because it's not, we don't know what is happening in vivo, but your labs are off. That's what I want to say. The resistance is your labs are off and you're calling your patient resistant to the heparin, and maybe because there's something else happening on the background.
And because they're so sick, we want to do everything we can. So we give antithrombin.
Because you want to see normal, I mean, not normal, but you wanted to follow the protocol having your target and numbers.
But we're not sure if it's doing anything or not, but because we're not sure, potentially it could help.
Right.
So in certain cases, with the hematologist guiding and helping us, we could give it.
Right, but I would say that in those cases, you need to be with a hematologist besides you. If you're having that.
How many times have you given antithrombin in your career?
I'm not going to lie. Dr. Monagli is going to be nervous now, but he use it, especially in the neonates, especially in ECMO. And neonates on ECMO, and then you have a life-threatening event you ended up using because of the heparin is not on target, and your patient is not doing well, and then you start using it. But in general speaking, if I'm not, I think that some folks using even more than they should be using. But sometimes, especially in those life-threatening situations, in neonates, I ended up using. But as I say, maybe I'm doing more than I should be doing. But I consider myself not as liberal as some of the other folks that are out there doing. In ECMO, I'm pretty liberal giving it for regardless the age. But some studies have shown that you have a longer length of the circuit, less incidence of clotting in the machine. But then the whole discussion of how to give antithrombin, how to avoid the peak of the antithrombin when infusing to cause bleeds and all this. So that's why I've done it, but I've done conservatively in a way, but not as much as some of the other folks are there, but not as little as some of the old hard school folks and that have been doing this for a longer time.
So this is an area of real discussion in hematology. There's a lot of back and forth.
Right.
I'm assuming there's research being done to help flush this out.
Right. I think that we were going to be ending up as seeing that we are being already seeing a change in those high-risk patients to bivalirudin or gatroban or who knows something new that's going to come up. Because those are direct drugs that you know exactly which protein they're working on, and that is a little bit easier in a way to monitor those drugs because they're not depending on antithrombin, and then usage is going to be less. But I'm not going to lie to you, there's been using more than should be using antithrombin replacement in pediatrics, and sometimes not correctly, I have to say that.
So we're going to jump ahead before we go back, because there's an article we went over that I think helps give some background information to a lot of this, and then we'll go back to our guidelines.
Okay.
So the article I'm going to jump ahead to is Perioperative Thromboprophylaxis in Children, Development of a Guideline for Management. This was by Philip Jackson and Judith Morgan in Pediatric Anesthesia back in 2008. Now, the research itself was just creating a guideline, how to develop a guideline for thromboprophylaxis. That was fine. It wasn't all that helpful for the talk. The intro was helpful for me. So for those of you listening, I'm going to read this out to you. So they talk about, one of the very interesting points is even a child with an inherited thrombophilic tendency, the majority of those individuals won't have their first venous thromboembolism until adulthood. And I didn't know that. And then they discuss theories behind that, but there's no known reason. And one of the things they talk about...
But I'm sorry, because most of the most common genetic mutation for inherited is the factor V Leiden mutation, right? And factor V Leiden mutation nowadays, we do know that is an adding risk factor, right? Especially if you're heterozygous for it. And then studies have shown that it is an additive risk factors that impact your risk, especially later in life, not in the pediatric side.
Right.
So that's why that it says that, because the most common is factor V, and then we do know that the factor V will impact your risk later, not early in life.
Not early in life.
Prothrombin gene mutation differently, then that is the one that looks like that it has a more risk throughout your life, doesn't matter how old you are, and especially in the central venous line related clots. But
so the prothrombin mutation you can see at any point.
That's what it seems like, that it has a more of a steady impact throughout your life than the factor V Leiden.
So they talk about this, the theory they have, one of the theories at the time, was the level of thrombin inhibitor, alpha-2 macroglobulin, is up to 3 times higher in childhood. They think that's one of the reasons. And then the plasma prothrombin concentrations are 10 to 20% lower in childhood, which affects the child's ability to generate a thrombus or thrombin.
Right.
And that may be the reason for the difference between adulthood and the young pediatric age.
Yeah, so this is all about the development of the hemostasis in pediatrics, right? So that's why nowadays we are revisiting even in neonates the threshold to give platelets, because we know that the platelets in neonates are less reactive than adults. So why to bring a higher threshold, giving like a way more reactive platelet to a patient that maybe doesn't need that higher threshold? But that's what we're trying to figure out. Still, there's not a lot of data out there, but that's why the numbers in peds, the normal values are different than adults. And then we should figure out this out to make formal recommendations for a specific group. That's why creating a standard prophylactic in a pediatric ward is so difficult, because you have all the 8 different groups, all the body types, disease risk, severity is very pleomorphic in the pediatric than compared to adults.
Right.
Adults that have a bad knee, usually they're obese and high risk and all this, so it's more of a uniform population that you're studying than in pediatrics that is like this crazy broad variety that we have.
And we're going to get into that. Now, one of the things they do also talk about is the risk factors for venous thromboembolism in pediatrics. They divide them into 2 categories, congenital or acquired. 2 of them on the congenital side we talked about, factor V lion and prothrombin mutations. There's also deficiency of antithrombin 3 and protein C and protein S deficiencies. And absence of these, typically they talked about families that have these mutations, and most of the children in those families won't have venous thromboembolism or thrombotic events until about 15, 14 years old. And then the acquired reasons for venous thromboembolism, infections like HIV, varicella, malignancy obviously, certain medications like L-asparaginase, etc., steroids, trauma and surgery, oral contraceptives, and then the single most important is obviously the central venous catheter.
And you missed the autoimmune inflammation ones. Right?
Autoimmune inflammation, I had that number 7.
So especially the IBD patients are super in high risk of having venous thromboembolic events.
So now we're going to go back to where we were. We were on our guidelines, because I thought, and in that paper, that introduction I thought was very well written, which helped. Now we're on recommendations 9 through 12. And here, they're all linked together.
Yes.
Here they're all talking about central venous access devices.
Right.
And they remind us this is the most common precipitating factor.
Right.
And they suggest, and this is what I found interesting, in not removing a functioning central venous access device, so central line, in a symptomatic patient with a symptomatic CVAD or central venous access device related thrombus who still needs the access. So a chemotherapeutic patient who still needs that access.
Right, so go through and treat it.
Go through it and treat it. And they said, again, there's low evidence, but they say in kids who have limited availability of sites, you have to consider how the thrombogenomic effects of placing another line causing endothelial injury.
Right. And then it's means like anesthesia and manipulating, then having a lag time without central line, and then keep getting sicker. That's why we say that if the line is working and you're treating correctly, go ahead, keep the line in, and go ahead with the anticoagulation. And of course, monitor it. Take a look every 2 weeks or so to see if the clot is growing, the clot is stable, the clot is getting smaller. Just make sure that you are doing, the therapy is working for the kid. But yeah, if you need the line, keep the line and sail through giving anticoagulation.
Now, the implication, and they talk about it, is that the risk of the clot is less than, or the risk of moving the line from one place to another is less than the risk of the anticoagulation itself.
Correct.
And that's what they talk, which I didn't expect. And now they say basically, I'm going to summarize it. They talk a lot about it. So if you...
No, the opposite, right? The risk of the removing is higher than the anticoagulation per se.
Yes.
That's why you
yes.
Yeah.
The risk of removing the line, putting the line, is higher than the risk of just the anticoagulation.
Correct.
And then they talk about, I'm going to summarize, that once you can remove a device and you don't need it, get the central venous device out.
Correct.
Once you're able to take it out, take it out.
Yeah, don't leave it there if you're not treating, because then your risk of propagation of the clot and then the clot is lodged and going somewhere else is high.
Then if you have someone with a line and they just finished their antibiotics and they have a thrombosis, they don't need it, take the line out.
Right.
They caution against and suggest delaying removal of a central venous access device until after anticoagulation, and they say days, is established rather than immediate removal.
This is a fear of having when you pull the clot traveling and causing damage. Right.
So if you have a kid with a PICC line, if the child just finished 3 weeks of antibiotics for osteomyelitis, they're towards the end. We do an ultrasound because the arm swelled up.
Uh-huh.
We find the clot around the line, not in the line, not including the line.
Right.
And we have one more day of antibiotics. We then start anticoagulation. You do the 1 day of antibiotics, wait for the anticoagulation to be therapeutic, then pull the line.
Right. Usually we say that 3 days.
3 days.
5 days. Yeah.
And then we just talked about that. Good. And the only time it's okay to remove a line in a kid who has related thrombus is if you have worsening signs and symptoms despite anticoagulation. The only time it's okay to remove a line in a kid who has, but continues to need the line. So if it's someone who you're not done
in the line and you're treating and the clot's getting worse, then you may have to take it out. Yeah.
So this has got to be one of the most common things we call you about.
Right.
Central line related thrombosis.
Most of the times you call me after you pull the line up.
Is that right? I didn't know that.
Yeah. Without even giving anticoagulation. Yeah.
So we have to give anticoagulation for 3 days, you say, to get everything, to get the levels therapeutic and get the patient okay, then pull the line so we don't have the thrombotic related.
Yeah.
And they don't talk about this, but what is the...
We don't know.
We don't know.
It's all from adults, yeah. And because that's why it's hard, right, to keep track of this. How many lines did you pull before calling the hematology? Some of them you don't even call. Our gut feeling is that in neonates, it looks like it's okay because of maybe physiologically they have a higher antifibrinolysis going on. But older you get, then you start like having the risk like the adults. Because in adults, this is like one of the risks that is described. Pulling line and clotting flying away. So that's the group that we say that, yeah, for sure we will say, if you ask them, we will say, yes, keep it and do it. But most of the times, as I say, that doesn't happen. You call after you pull the line already. I say, oh, yeah, we have a clot here, we already pulled the line, so can we start interrelation? And you say, yeah, well.
It's usually, but we don't know what the percentages of kids that have this happen, where you pull the line. No. Okay. Have you seen it happen in your career?
No.
You've never seen it?
No.
Okay.
Yes.
Even in the older adolescent patients?
Adults, yes, we hear about it, but in pediatric groups, no, we haven't heard.
Okay. So like a 15-year-old, you haven't had one?
No, because as you said, right, in peds, most of the kids are sicker and they need the line. And then they call and then say that you need the line. The younger ones, they pull the line because they are done anyways, or you can just switch or something.
So now this recommendation answers the question, which anticoagulant should I use in a patient with a symptomatic DVT or PE? And they say low molecular weight heparin or a vitamin K antagonist.
Correct, because those are the ones that achieve therapeutic levels faster than the heparin.
Good. And then
we like low molecular weight, Tony, you know that.
We use it all the time.
Right.
I think that's one of the.
And then here we do monitor them with anti-10. We don't do PTTs anymore. If you were hearing this webinar, you should fight for having anti-10 level performed in your place and give up about monitoring heparin with the PTT. I'm not saying that PTT is not useful. It is, because it gives you the background to, like, if you need to replace something else and to keep an eye on your patient in terms of DIC, but you should really adjust those based on anti-10s, not on PTTs. PTT is your safeguard. You need to monitor PTT just to know what's happening in the background of your patient.
And we do anti-10 levels here in-house.
Yes.
Good. Yeah. Good. And then now the recommendation 14 suggests using anticoagulation for less than 3 months rather than for greater than 3 months in pediatric patients with a provoked DVT or PE. And they say the exact duration for optimal anticoagulation was unknown, and there's ongoing studies. And then if the provoking cause does not resolve, of course, then you go for longer. But this sounds like they were hedging a little. Less than 3 months is a big number. I mean, it's anywhere from 1 week to 11 weeks. But you're thinking it's going to be smaller than that at some point.
No, because still the little tiny ones, the risk of a head bleed is still significant, right? So that's why this group population, we always need to weigh the risk and benefits on them. And then we are one of the sites doing the study, right? It's the kids dot that's going internationally to decide if 6 weeks is enough, and maybe even like those little ones, even shorter than that. We need to tease out this particular group because all the idiosyncrasy of this group population with the developmental aspect of the hemostasis is completely different on them. And that's what we need to learn.
Now, they use the word provoked DVT or P, and they never define it, but the assumption I have is central line trauma surgery.
Right. Especially those little ones is most of the time central line. Right. Those like tiny little babies with the massive peak lines, triple and fourth. Yeah.
Okay, so that counts. Good. Mm-hmm. The next recommendation, they suggest you anticoagulating for 6 to 12 months in a pediatric patient with unprovoked DVT or P. So we don't know how it got there. It's there. Then you got to do 6 to 12 months of anticoagulation.
Right.
And that's also a big number, but is that dependent upon what the ultrasound shows how the child looks?
No, it's I mean the clot once you start intubation shouldn't go bigger. Okay. Right? Otherwise you have to rethink what you're doing and assess what's going on. But some of the kids, as I said, that we don't know who is going to have a complete resolution of a clot and who will not. But that's not what is going to determine your length of therapy, right? Because as I say, the anticoagulation doesn't do anything to the clot itself. Your body is the one doing it. And at some point, that clot is going to be reabsorbed and coated with the new endothelial cells as well. It's just the flow that is going to be abnormal, and then the risk of post-thrombotic syndrome is what's going to happen. But sometimes, yes, sometimes the clot will remain there. And that's not what's going to, that we're trying to understand what is the length, right? Because the length of the therapy is when your risk of bleeding passes your risk of recurring the clot. And also nowadays, more and more, we're thinking about if there is any relationship between the length of your therapy to the risk of post-thrombotic syndrome. So those are the most decisions to make. And also the recurrency, right? The unprovoked. That's why in Europe, right, they do advocate to not doing genetic testing for anyone or prothrombotic workup if you don't have a history of clot, because that's one of the reasons. We measure everything, we do the labs, but do we know all the risk factors for congenital ones for developing? We may not even know all of them. And then that's the question, that the unprovoked ones, maybe you have something else that we don't know, and that's why we need to treat you longer, because your chance of recurrent is higher.
So then how do you decide between 6 to 12 months?
Because that's what the physiology comes on top, because that's when your clot is going to be completely coated on with the new endothelial cells, and your chance of recurrence is going to be less. And then your post-thrombotic syndrome, the people believe that in 12 months is when your risk of bleeding starts going off the chart, and you should stop it.
No, but so then in between 6 and 12 months, like
that's
7, 8,
case by
9.
case, right? That's why the hematologist needs to be involved to decide what it is.
Okay. So the next recommendation, the 16, it made me laugh. 16 made me laugh because it states what you could or could not use anticoagulation in a patient with a central venous access device related superficial vein thrombosis. There's a very low evidence base to do whatever you want. So I thought that was funny.
We are becoming more and more aggressive, I think, Tony, because this is started. There's a New England Journal of Medicine article called Callisto that they show that in adults, lower limb, superficial vein, the anticoagulation improves symptoms and looks like to decrease your risk of propagation of the clot. So that's the question, right? Why to treat the superficial clot? Is because of the symptoms and the risk of propagation. So that's why then people try to come up with, how close the clot is from getting into the deep system. And then, in pediatric, the size, so that's why it's just hard to establish a number, because proportionally the kids, right, it's all different. And the symptoms, who is going to have more symptoms, who is going to have less symptoms. So that's why we don't know this is on. We are becoming more aggressive. I think if the patient is having symptoms from the clot, I think that we are treating more towards treating that to improve quality of life, because we know the anticoagulation nowadays, if you're doing on a right way, the risks and benefits and all this is safer when doing by someone that knows what you're doing. So that's why I think that we're becoming more and more aggressive in terms of doing that. I think that the superficial vein thrombosis should be considered separately if you have a line there, right? Like, for example, a PICC line. You have a PICC line and then develop a superficial vein thrombosis. That I think that those are the cases that needs to be thinking. You need to consider carefully because the risk of propagation, because the line is sitting there, is high. So then I think that those should be treated regardless. But the other ones, especially in pediatrics, because it's so rare to see those, right? And then you have to also start thinking about, is there any anatomical condition behind that? Is there any paraneoplastic syndrome happening in that patient? Because why they're having superficial vein thrombosis? So there's a lot of different things to try to put all those patients in a bag and trying to decide who to treat and who not to treat. But my feeling is that we are becoming more aggressive, yes. So but the length is way shorter than a deep system.
Oh, length of treatment.
Right.
How long do you treat for?
So here we do 4 to 6 weeks, no more than that.
So and when you say PICC line, you could also mean a central line, triple lumen, in an ICU patient for the superficial thrombosis.
No, because the PICC starts on a superficial vein and goes deep, right? All the other central lines, they start deep anyways. So okay. That's why I said that.
That's interesting. Yeah. So it sounds like for a lot of the consults that you get, there's no straightforward answer. Everything is, what does the patient specifically have, why they're having it, and it's a lot. Right. It's not easy because there's so much unknown that it takes so many factors into consideration.
The first is the risk and benefit, right? So what's the risk of bleeding and what is the risk of that clot causing trouble? Second one is, if it is truly provoked or is not provoked. There's something else happening to your patient that you have to think about it, right? So that's why anatomical considerations sometimes are missed, like May Turner, as I said, thoracic outlet syndrome are things that we always need to think. Extrinsic compressions like masses elsewhere, sometimes even like higher to the clot causing stasis in the whole limb. Sometimes is one of the things we have to think about it as well. But that's why it's case by case. It's not easy. Most of them are straightforward. You have a line, you have a clot, patient is okay, you start anticoagulation, and then you decide if the line needs to be there, doesn't need to be there. But sometimes it's not that straightforward, and the patient is super sick, the risk of bleeding starts getting higher, and then you have to think what you should do, and then most of the times a team discussion. CSVT is a big one that most of the kids, they have some kind of bleeding already when you think about treating the clot there. So it's that's why it's hard to standardize because the patients are not the same, especially in pediatrics.
Now we're getting into the home stretch. If listening at home, we're on recommendation 17. I got another written page here of stuff we're going to talk about. The next is 17 and 18 talk about right atrial thrombus. I don't know how often we see that in hospital medicine, but we see it in the ICU and cardiology sees it.
We see a lot.
You see a lot of it.
Yeah. Central lines are called a little bit further in, they cause clots.
So they couldn't differentiate between symptomatic and asymptomatic venous thromboembolism in these cases.
Right.
They recommended.
It's always an echo, and if you have an echo, you have a clot, and then you. Oh yeah, go ahead.
No. They recommended against thrombolysis or surgical thrombectomy, followed by standard anticoagulation in a kid with a right atrial thrombus. They did state that, like everything in medicine, there may be individual cases where the hemodynamic status, the size of the thing, the mobility of it, may dictate more aggressive therapy, but overall they recommend against that.
Right, because most of the times the line is a little bit deep in and causes a trauma in your endocardium, and you have a flat clot. Okay. So the ones that we may think about doing something different are the pedunculated ones that are mobile, because then the chance of dislodging it and flying is higher. But those are extremely rare. Most of the times they're a flat clot that you see. The ultrasound says, there's this shadow over here, and they're pretty much straightforward. You start anticoagulation. Is a high flow organ heart, so you don't need to do the whole 9-yard, 6 weeks to 3 months. You can do short in that. You almost do almost an arterial clot. But you keep repeating imaging. Most of the times you're going to have a residual image there. Then you have to decide if that's a clot or if that's just a scar. And then should we stop, should we not stop? So that's a job for the cardiology and the hematology to do as well. But most of them, you start anticoagulation because the clot is there. So
we could, with a central line that we use for lots of stuff, we could see this.
Right.
Okay. The now recommendations 19 and the 20B are talking about renal vein thrombosis. They recommend using anticoagulation in neonates with renal vein thrombosis. The reason is obvious, that they want to try to avoid hypertension, renal damage. They recommend against thrombolysis followed by anticoagulation in non-life-threatening renal vein thrombosis. The reason, they said, came from observational studies,
right,
where patients treated with thrombolytics were typically unwell. They were very, very sick, and they didn't do as well, but and they went, the clots were usually bilateral renal vein thrombosis and inferior vena cava. And so they said in life-threatening renal vein thrombosis, they recommend thrombolysis followed by standard anticoagulation. Those kids, I guess, are much sicker typically.
Right. Yeah, so those are the ones that we don't know because of the risk of bleeding is already too high. Right. So the typical renal vein thrombosis, the mass hematuria, and then you do an ultrasound, you have the clot there. And then they already have a hemorrhage, adrenal gland hemorrhage. Most of the kids will have already, or you're going to progress anyway because it's the natural history, and then you don't know if because it's your anticoagulation or not. So that's why the question is that. But the ballpark you said. So if your patient has bilateral clot, or you have any impairment of your renal function, you should think about being more aggressive. Other than that, you just do the standard anticoagulation.
Good. 21A and B talk about portal vein thrombosis. They suggest using anticoagulation instead of nothing for a patient with portal vein thrombosis with occlusive thrombus, post-liver transplant, idiopathic. They also say do nothing except follow-up monitoring in a patient with a non-occlusive thrombus or portal hypertension. So for those patients, if there's non-occlusive, they'll self-resolve. You just observe.
We don't know, yeah.
So, okay, good.
But that's why most of the institutions, Tony, that they have a hematology team on board. Like here, we have our protocol because we are trying to standardize. Because liver is a different organ, we don't know. But yeah, the rule is like if it's a completely occlusive clot, you most likely going to treat it. Or if you have impairment of your renal or your hepatic function, you're going to treat it. But those subocclusive ones, we don't know what to do with them. But if you decide not to, I strongly advise to keep doing at least once every 2 weeks or once a week ultrasounds to make sure that the clot is not growing.
Now the last two for the guidelines, 22 and 23, are about cerebral sinovenous thrombosis, and we see these quite a bit.
Right.
Now, first they say, and I want you to, if you're listening at home, pay attention to the wording. They recommend using anticoagulation in a patient, pediatric patient, with cerebral sinovenous thrombosis and no hemorrhage. Then they suggest, they don't recommend, using anticoagulation in a pediatric patient with cerebral sinovenous thrombosis with hemorrhage. And it's surprising because they say that patients with intracranial hemorrhage were included in studies with lack of specific evidence. They felt that these kids have worse outcomes, so they recommended anticoagulation. And they also suggested against thrombolysis followed by anticoagulation. And they said typically kids who got thrombolytics in the studies were sicker, had worse outcomes, so there's very low certainty in the evidence. And there's not enough data to support any type of subgroup recommending thrombolytics or not.
So this is two questions in that, right? So the first one is what happened first, chicken or the egg. So is your clot caused because you have a bleed and then you bleed, mass effect, compress, and then you clot? Or opposite, you have a clot and then you're causing venous stasis and then you bleed because of poor drainage. So that's the first aspect. So we believe that if your clot is causing the bleed, we would recommend you to go ahead and treat it. And then the second thing is that is your anticoagulation going to make a catastrophic hemorrhagic transformation, right? We know that most of the venous strokes or infarcts are going to transform in hemorrhagic anyways, and then it's going to be a problem of what is that hemorrhagic transformation? Is it too much, or is what is going to be expected? So that's why it's a whole team. Neurology needs to be on board, neurosurgery needs to be on board, hematology needs to be on board. Because as the suggestion says, that we will most likely recommend anticoagulation if we think that the bleed is a consequence of the venous stasis on the brain. However, we don't want it to kill your patient bleeding, having a massive hemorrhagic transformation in that area that is already stroke, that may even be the natural history of those cases. That's why sometimes we wait if the hemorrhage is significant enough, like 72 hours or so, readdress, and then start then, because then your risk of having even more bleed is going to be less, because the natural history already happened with the bleed that will happen anyways in a hemorrhagic stroke. And then you start your anticoagulation, and you're not going to cause more problems, you're going to help that brain to heal. So that's the recommendation.
So if I'm understanding this, the question is always what came first, the bleeding or the thrombus. In most infarcts, strokes caused by a thrombus, eventually there'll be some bleeding. And you like to wait, typically is recommended to wait 72 hours after you have the infarct to see, and if there's a bleed with it, to see if the bleed is going to grow or not grow before you decide to start anticoagulation.
Correct.
Because if it's going to grow more, it's going to grow within that 72 hours. And then if you give anticoagulation too soon, you could make that worse.
Correct.
But if after 72 hours it's grown as much as it's going to grow, so your anticoagulation you don't think is going to worsen the bleeding much at all, and it'll just help with the thrombus.
Right.
Okay.
But yeah, if the bleed is not significant enough and you think the bleeding is happening because of the clot, yeah, go ahead and treat it. But as I say, you have to have all your team agreeing with you.
So everyone on board.
Right.
Does that happen a lot where everybody agrees?
Yeah, it does. So, especially in centers like here that we have a fair amount of experience. Of course, those patients need to be in intensive care.
Yeah. All right, so now we've just finished talking about the American Society of Hematology's guidelines for the management of venous thromboembolism that was published in November of 2018. We've gone into an hour and we're over our time. So I'm going to bring Dr. Xavier back to do thromboembolism prophylaxis in pediatrics. That's a long topic. It's not easy. And we're going to talk about it then. I'll do a second episode on this. In the middle, I'm going to do an episode on rheumatology. I'm going to bring one of our specialists in here to talk with us about that. So for those of you listening at home, we're going to do another episode. And I wanted to say thank you to Dr. Xavier for joining us today. I appreciate your time. This was a really nice discussion.
Tony, that was fun. Thank you so much. And hopefully I helped a little, because I know there's not enough evidence, and some people say that hematology is not very useful because we never have a strong answer to do. But we're trying, and hopefully if you're listening and you start collecting data as well, creating an organized database, you will be able to help us out to generate more data in pediatrics. Thank you.
Oh, thank you. So now, acknowledgments for the podcast. I want to thank, in addition to our guest today, I want to thank the Paul C. Gaffney Division of Pediatric Hospital Medicine, lets me keep doing this. I want to thank the hospital that allows me to keep doing this as well. I want to thank all of you listening at home. I appreciate your time for listening with us. Of course, I want to acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. Just a quick announcement for everybody. The AAP Society of Hospital Medicine Executive Committee will be having a national election in March, so please make sure to vote. Thank you all again, and we'll see you next time on our next episode. If you have any suggestions or comments for a podcast, compliments, or anything, please feel free to email me at tony.tarchichi, TARCHICHI, @chp.edu. We'll see you next time. Thank you.